Okay, welcome, folks. We are going to be talking about a very interesting case today, and we're going to use it to think about one of our four principles of medical ethics, the principle of non-maleficence. So, you might remember our four principles for medical ethics that we're using as a focal point for this class. We've got beneficence, the duty to help; non-maleficence, the duty not to hurt; justice, the duty to fairly distribute benefits and burdens, respect people's rights; and then we've got autonomy, the duty to respect the decisions and to empower good decision making in patients. But yes, so today our topic is going to be non-maleficence. We can think about this as, in very simple terms, the duty not to bring harm to others, or the duty not to hurt others in our medical treatment of them. So we're going to be learning about a story from this fellow right here, Travis Rieder. Now, Dr. Rieder is both a bioethicist, so somebody trained in philosophy, kind of like me, who does work in the medical realm, but who also has a really interesting and compelling narrative as a patient. So we're not just going to be thinking about Rieder as a philosopher, but we're also going to think of him as a person who had a really horrifying ordeal within the medical system. So let's learn about Rieder's story, and we'll try to see what kind of lessons it can draw us towards when it comes to non-maleficence. So yeah, that's the plan. We will think about Rieder's story, and then we'll think more broadly about what doctors owe to their patients when prescribing opioids. The paper that we're going to be looking at is this very short paper that was published in Health Affairs called "In Opioid Withdrawal with No Help in Sight." But you'll see here, he eventually expanded this paper and his thinking about pain management and opioids into an entire book. In Pain, subheading "A Bioethicist's Personal Struggle with Opioids." One other resource that I've linked for you in your media reactions assignments is an interview that he did on a very good interview program called Fresh Air. Anyway, let's get into Rieder's story. So Rieder was involved in a terrible motorcycle accident in 2015. What happened was he was out for a ride. A van blew a stop sign, I believe, and his foot was trapped and crushed between the van and the motorcycle. And it involved several surgeries to manage Dr. Rieder's pain, including what is called a free flap surgery. He had bones coming out of his feet from this horrifying incident, and what they had to do was remove a large amount of skin and tissue and nerve material from his thigh. They call this a free flap surgery, which they used to fix him up. As you can imagine, he was going through an incredibly painful experience, so he was given drugs to manage his pain. Oxycodone, along with morphine through an intravenous delivery, fentanyl, and diolidid. So these are serious, heavy-duty pain management drugs, and we might, on the one hand, just react very badly right at the start here, thinking these doctors shouldn't have given Dr. Rieder so much drugs. But we might also realize he was going through excruciating pain. And drugs like this can actually make life manageable. So it's not necessarily a bad thing that he was given these heavy-duty pain management drugs. I believe that Rieder would even admit so much. In his book, which I did not have you read, but he mentions that before he went through withdrawal symptoms, dealing with his pain management on his foot in his subsequent surgeries, said that he hit a 10 on his pain scale. You'll sometimes hear doctors ask on a scale of 1 to 10, where 1 is just mild discomfort, and where 10 is the worst possible pain you can ever imagine having had in your life. You couldn't imagine having more pain. Maybe you would say, if I was in any more pain, I would simply black out. During his ordeal of saving his foot from being amputated, he basically hit a 10 on the pain scale. This is why these drugs are brought in to these situations. Now, as time went on, they also upped his oxycodone. They added intravenous acetaminophen into the mix, as well as another drug, gabapentin. And in these cases, doctors were generally willing to up his doses. If he said, look, I think the drugs are not helping me stay on top of the pain, they would increase his levels on drugs like oxycodone. And about 3 months out from the accident, an orthopedic surgeon suggests that Rieder lower his doses. And in order to get that tapering regimen worked out, Rieder was referred back to the plastic surgeon who was reconstructing and replacing the skin on his foot. And his plastic surgeon says, okay, yeah, I think it's time to get you off the opioids, and recommends to Rieder that he drop his doses by 1/4 a week. So if you're taking 4 pills of oxycodone a day, take it down to 3 this week. We'll take it down to 2 the next, 1, and then down to 0. So we'll drop 1/4 of the original dose each week. But this Rieder will come to realize was an overly aggressive tapering plan. So he started to feel bad when he was at 75%. At that point, he was feeling nauseous, feverish, and was sleeping very badly. It suggests that by the end of this week, he was almost starting to feel better, but then he drops another 1/4 of the drugs. And at this point, in addition to the nausea, feverishness, and poor sleep, he also finds himself just completely depressed, crying spontaneously, feeling like he's broken and will never be fixed again. At this point, when he's going to see his doctors, a lot of what they're asking him about his medications is one of the unfortunate side effects of opioids is about constipation. So it seems like the main thing that they're asking him about is how his bowels are doing. But when he mentions how bad the symptoms have become from the withdrawal, the doctor tells him, well, if the withdrawal is too much, you can just go back to your original dose. And at this point, Rieder, in consultation with his wife, decides not to do that. He didn't want to get back on the drugs if he was just going to have to go through the withdrawal again. If there is no plan to quit, they decided they were going to try to stick it out, tough it out as long as they could. Now, in week 3, Rieder finds himself not only struggling with the original symptoms, but they're getting worse, right? So not only is it poor sleep, but now it's like pretty much no sleep, extreme difficulty sleeping, severe depression, a burning feeling throughout his body. And by week 4, at this point, he's off his pain medication entirely. He's going through extreme nausea, suicidal thoughts, he says, for the first time in his life. And at this point, he's like not even attempting to sleep and basically just curled up beside the toilet because of the nausea. And Moving from doctor to doctor, Rieder finds that the prescribing pain management team claimed that they did not treat withdrawal. So they basically said, it's our job to get the pain under control, but it's not our job to treat withdrawal. You should probably speak with addiction specialists there. But when Rieder and his wife called addiction specialists, they basically said, well, we don't deal with pain management withdrawal so much as people with other kinds of drug problems. So what ended up happening to Rieder in the end was he filled another prescription, that is, got another bottle of his pain pills, the lowest dose he could get, and said, if I cannot get to sleep in 4 hours, I will take these drugs. He put them beside his bed, and thankfully for him, he was able to find sleep within that period of time before he had decided he would take drugs if he couldn't. So he came through it. But we'll also notice that Dr. Rieder was put through the worst month of his life, probably just about as much suffering as any person could go through. So here we might think that the medical system failed him in a tragic and angering way when he came through this experience, and I think that we can understand and sympathize with him. Dr. Rieder said he came out of the situation feeling very angry. And once they were able to step back and look at the situation, they realized that in this situation, his medical team failed him. So what should have been done? Well, one thing to notice is that the tapering schedule that plastic surgeon gave Rieder was completely unrealistic, right? So while the plastic surgeon was saying, well, take each of your meds, chop off a quarter of your dose each week, well, it turns out, A, you should be tapering medications one drug at a time, and you should be reducing the dose by as little as 10% a week. So 25% is far too aggressive. 10% is probably closer to what you want to be managing with. There are also other drugs, such as naloxone and I believe buprenorphine, that are able to help a person with opioid dependencies manage these drugs by basically blocking receptors and by managing chemical imbalances in a body. And this way, we can stop some of the effects of opioids without replacing it with another problem. That's part of what naloxone can be good for. Rieder mentions that after he published this article in Health Affairs, the CDC tweeted at him. Of all organizations that could tweet at you, it's interesting that the CDC tweeted at him, basically saying they had this pocket guide, basically a simple 3-page report that doctors and other healthcare professionals can read to understand how to properly taper an opioid in a chronic pain patient. And it does follow this 10% kind of rule. So we've learned this really horrifying story. Here's the principle behind the case as Rieder sees it. He says that each physician has a duty to prescribe only those medications that he or she can responsibly manage for the length of a patient's need, including the treatment of foreseeable side effects. So, for instance, we would say, you should not be giving a patient opioids if you can't manage their withdrawal. In a similar way, we might say you should not be giving a patient chemotherapy if you are not able to manage the foreseeable side effects, all the pain and suffering and nausea that comes along with chemo. Now, Rieder says this could be seen as a specification of a recommendation from the Hippocratic Oath. The Hippocratic Oath is this ancient Greek code of medicine. Some of you might have learned about it for one of your media reaction assignments. Or you might have learned about it in your reading from Cass. But the Hippocratic Oath, one of its large recommendations and one of the most important things that we can take away from the Hippocratic Oath and still agree with, even if there are other problems with the oath. The Hippocratic Oath says, first, do no harm. Right? So the idea here is that when you work with patients, you want to make sure that you are responsibly managing the harms that come along. Now, we notice that sometimes you actually do have to harm a patient in the process of helping them, right? So you will harm a patient in the process of giving them chemotherapy. It's just that the benefit through our principle of beneficence is going to outweigh the harms that the principle of non-maleficence recommends against. But, even in the case of chemotherapy, we would condemn an oncologist if they did nothing to help a patient manage those painful, harmful side effects. Right? So in a similar way, Rieder's pointing out that in the case of opioid withdrawal and pain management, if there are foreseeable side effects like dependencies on these drugs, which there clearly are, you have to be prepared to help a patient manage that kind of dependency in a way that is helpful and in a way that it is informed by the best evidence, which clearly Rieder's plastic surgeon failed in this way. So just to put it in other words, as Rieder's thinking about it, if a physician is opening a patient up to predictable harm, even for a very good reason, like chemotherapy, saving a patient's life, right? The physician needs to be doing what they can to minimize that harm. Right? So we can think about this harm minimization principle, harm management, and taking responsibility for harm as a really clear illustration of what we need to be worried about when it comes to the principle of non-maleficence. So part of non-maleficence isn't just keeping your hands off, because, well, we need to help our patients along the way, but you also need to know how to predict, avoid, and manage harms as they will come up in caring for our patients. So we might ask a couple of questions. Why is it so hard for physicians to withdraw medication or to taper medication for patients responsibly? Well, we might notice a couple of things. One is that physicians are not adequately educated about opioid use, right? A lot of the education in the past about opioid usage was provided to doctors by drug companies. So, for instance, companies like Sackler Medical that was producing OxyContin, well, they were telling physicians that these drugs were not habit-forming, not dependency-forming. And in medical schools, there is not an awful lot of information given to students working on their MDs on pain management. The sort of shocking or striking fact that Rieder points out is that the statistics and the data have pointed out to us that Canadian veterinarians have more training on pain management than US medical students. So one thing that we might think about is, like, if we want to prevent this kind of thing that happened to Rieder from happening to others, we do need to talk more about how to responsibly prescribe pain medications and also how to responsibly taper a patient off of them eventually. One thing that we'll also notice in Rieder's case is that we get important questions about how jobs are delineated, right? One way we might look at Rieder's situation is, well, when he goes to the plastic surgeon says, well, I don't know how to manage your pain management or your tapering. So I'm going to send you to the pain management team. The pain management team says, oh, we manage people's pain, but we don't get people off of drugs. It seems to be in a pretty clear violation of this principle that Rieder has given us. This principle saying, if you give somebody a drug, you have to be able to manage it, or at least refer somebody to people who can. But of course, the pain management team sends him to addiction medicine that is not prepared to help him either. Right? So we do need to ask questions about taking responsibility for a patient, and we want to avoid situations where we have pain management teams who are quite prepared to prescribe medications, but who are not prepared to help a patient going through withdrawal. As Rieder puts it, given the physiology of dependence, we know that a number of patients who are prescribed opioids will require care for that dependency. As a community, we need to decide whose responsibility these patients become, right? And in team-based medicine, it's often unclear who owns the patient at any given time. So one further thing beyond just giving better education about opioid management would also be a structural suggestion that we need to have conversations about whose responsibility it's going to be when these sorts of predictable withdrawal symptoms emerge. Okay, so I'm going to stop talking at this point. So let's just sum up some of the main ideas that we should be taking away from this reading. First, in Rieder's case, his doctors did not know the correct tapering plan for his situation, nor was there adequate responsibility taken for his opioid withdrawal. So we can see Dr. Rieder's case as a failure in the principle of non-maleficence, right? One of the big duties in medicine is to do no harm, and clearly harm was done to Dr. Rieder in this sad situation. Thankfully, he came through it, and he's going to notice that solutions to this problem are going to be both structural, so we can think about how we set up our medical systems, how we make sure people are taking responsibility for the right cases, and there's also an educational aspect to it, right? We need to be making sure that physicians and prescribers get the information that they need about how you're going to get a patient off of pain medications once you've put them onto them. This leads to a broader lesson about part of what you need to do if you're going to work in the healthcare field is really know your stuff, right? Because if you don't know how to properly, not just prescribe pain medications, but also how to properly suture a wound, how to properly follow up on a case, you could be bringing your patients in for a lot of harm. And that's something that we want to avoid whenever possible as healthcare workers. So I'll leave you with that closing thought. Thanks for listening. And as always, don't hesitate to get in touch with me if you want to clarify anything or if you have any questions at all. So thanks for listening. Take care.